And as often happens on a lot of the podcasts I listen to, I get to know a lot of your guests. I love your episodes. Your podcast is one that I listen to every single week. It's one of the few that I keep on rotation and listen to all the time and get to meet new personalities and that kind of thing. But I don't often get to dig into either one of your stories. Like I know about you and I get to know you through the episodes, but I don't often get to hear about your own personal story. So if you wouldn't mind, tell us how you decided to get into medicine to begin with.
It's kind of random. I have no doctors in my family at all. I studied in high school as a 4.0 student. I played football and wrestled. So I had, academia and I got into UC Irvine. And I was going there and I thought, maybe I want to do something to help people. So I was thinking maybe physical therapy or, training or something like that because I enjoyed sports. And then one of my buddies said, "Hey, these guys, these doctors from USC are doing this thing called Flying Samaritans. They're going down to Mexico to medical clinic." I'm like, "Yeah, I don't really like doctors. I don't think, man. They're kind of arrogant and pompous and all this stuff." So I said, I'll go down and check it out. So I went down, and these guys were amazing. They were helping people and so kind and compassionate. They brought meds down. I saw what kind of impact they had on these little communities. And I was like, wow, this is pretty cool. And one of the guys actually that really impacted me. He was from Nigeria and he came over to the US, got into USC medical school, and he didn't tell his parents what he was doing. He told his parents like, "Yeah, I'm just working as a waiter." I'm like, and he got his medical degree and went back and surprised. Like in Nigeria, you get a medical degree, that's like an amazing feat. And he put himself all the way through school and took care of all that stuff. So I just saw that and I go, these guys are just really, really cool guys. And so I said, I'm going to apply to med school and see if I can get in. And fortunately, I got into USC also, just like those guys. And it was like never looking back, once I got in there.
That's cool. Did you decide on any kind of specialty that you wanted to focus on, or was it always just family medicine for you?
Yeah, I didn't know. I ended up in internal medicine mostly because of mentors. I had this old doc, and you kind of learn, you pick up stuff. And this old doc, I was just a med student, and you had to rotate through people's offices. And then I went rotate through gynecology, I rotate through general surgery. I'm like, my temperament is not gonna fit these guys. In academia, they're very short-tempered and very like burned out, tired, hate the world. They're getting up at 3 in the morning all the time. It's a tough career path. And then I was in this Marcus Welby office with this old doc, and he goes in, and I'm thinking, what the heck is this guy? He's not doing medicine. All he was doing was talking to the person. And like, they're carrying a conversation, laughing and, having a good old time. Then he walks out and I'm like, that was the visit. And he said, well, Brian, look, her dementia is stable and doing better. This is, and he gave me a whole list of everything he observed just by having this little conversation with this patient, and I go, this is kind of cool. There's an ongoing, you get to know the family and the kids and you have an impact. And, there's such a personal ongoing, if you're a surgeon or even in the ER, well, sometimes they have frequent flyers. They're there all the time and they get to know each other. But a lot of times the person comes in, they're at their worst. And I love ER docs. Their temperament is amazing, but it's a different, like you've triaged them and you send them home. And a lot of times they never even know. But the good ER docs that I worked with would ask me like, "Hey, Brian, that patient we sent up to the ICU last week, what happened with them? I mean, how do they turn out?" And they're curious about what happens. Other docs never ask.
Interesting. Yeah, that's interesting. Knowing you and your personality, that is the perfect way that you would want to practice medicine, is getting to know people, building that kind of relationship. So what was the reality? What was it actually like to practice medicine?
Wow, I'm giving a talk this weekend on that, so I was just reliving it. In the standard practice model. Now I'm direct primary care, so it's two different worlds completely, right? So I was frustrated in the system. I loved it. I loved the patient time one-on-one. We're in the room, we're taking care of stuff. But I saw that patients were getting worse and worse. And the standard of care was throw a drug, throw another drug, and then, have them come back in 3 weeks and we'll reevaluate how the drug's working. And the patients were getting sicker and I couldn't take it. And then, of course, one of my patients walks in one day, and just to give you a flavor, I was working 16 to 18-hour days. My appointments were, 12 to 15 minutes. And, maybe a annual exam I'd have 45 minutes or so with the patient. And I realized, gosh darn it, if we could just get in here and do preventive medicine, but in 15 minutes, how are you going to talk about family, drugs, alcohol, stress, sleep, all these things that we know are critically important with metabolic health? And so I started getting frustrated with that because what I would do is once I had one patient who lost 40 pounds. And I said, well, how'd you do it? Because I'm always trying to, and I was gaining weight and pre-diabetic at that time. And I said, how'd you do it? And he goes, you're not going to like it, doc. I did this thing called the fast diet. I go, there's no such thing as a fast diet. You have to do it slowly. Well, I'm talking about all these things. And he said, well, it worked fast for me. And I said, what'd you do? He's like, I fast on Tuesdays and Thursdays, I eat 500 calories or less, no carbohydrates. I said, okay, what about the other 5 days? He said, I eat whatever I want. So I said, you having pizza and beer and that? Yeah, yeah. I said, that doesn't make any sense at all. Because if you starve yourself on Tuesday, then Wednesday you must eat twice as much to make up for it because you're hungry. He said, no, it's weird. When I fast that day, on the next day, I'm not hungry. And I'm kind of forcing myself to eat. Even though I can eat whatever I want, I don't. And I stopped eating all this like processed food basically. And he said, I felt so much better. My joints got better and all. And so I was like, that's weird. So I go and Google, of course, and I look and I'm like, fasting, the benefits of fasting, how's it work? And then I was like, oh, come across Jason Fung, who subsequently helped us get the podcast started. And he's talking about fasting. How's it work? You're lowering your insulin. You're making yourself more insulin sensitive. So I'm like, this is crazy. What's this guy selling? And he wasn't selling anything at the end. So I said, I'm going to reach out to this doc and see what he's doing. So I reached out to him. He got right back to me. Great guy. And he said, look, the day before you put someone on insulin, their insulin is going to be the highest it's ever been. Because we think your sugars are high, we have to give you insulin to get the sugars down. But what if your insulin is not working anymore, your insulin resistance? So he explained that concept to me. And once I understood, I thought, holy cow, oh, so I'm going to start cutting my carbs. So at that time, because I was so busy, I was having a green shake for breakfast with a bunch of carbs in it, basically, right? Then I'd have like uh, um, rice cracker with a little peanut butter at lunch. I would, and a whole wheat toast, like the ADA's recommended diet, basically, right? And I'm gaining weight and my sugars are getting higher. Now I'm watching my patient getting better. So I'm like, I'm gonna try what this guy did. And I start doing that and I lose like 30 pounds. My A1C normalized, everything gets better. And I was like, wow, this is just wild. So
Wow.
then patients started noticing, they would ask me, like, Doc, what are you doing? I'm like, Professor Noakes was on trial at that time, by the way. I'm like, I can't really talk about it, but this is what I'm doing, but I can't recommend it to you. But if you want to do it, this is what I'm doing. And one of my patients, I learned it from him. So this is what I'm doing. And so that patient's still my patient to this day, and he's doing fantastic. And I learned a great deal, and I started researching insulin resistance. What is metabolic health? How do the mitochondria work, and all these things that we never talk about in medicine, And
Yeah.
in 6 months, I had 11 people come off insulin. And it was incredible because I'd never seen that before. I'd hear the naturopaths and the chiropractors saying it. And I thought they were nuts because once you're on insulin, you don't come off insulin, right? It's impossible. But then I started saying, well, it is possible, right? And then I could use that with my new patients and say, we could get you off insulin if you work with me, right? And then we started doing that. And it was amazing to see that because, I'm seeing all my partners putting people on more and more drugs and my patients are coming off meds and they're happier and they're feeling better. And then we have that social visit like that old doctor that I first learned from.
Wow. It's such a sticky situation, especially back then. I think now it's a little bit easier for doctors like yourself to be able to talk about these kinds of things. And we have conferences and a lot of research and that kind of thing. But especially back then, even just a few years ago, it was a lot more challenging. So you just said that you had never really been taught about mitochondrial health and insulin resistance and that kind of thing. I love asking doctors this question. How much study did you get in college, in med school, about nutrition in particular and how it relates to health? And would you want that to increase from where it was? Or do you think if that was increased, that they would just further teach some of the bad stuff that we know today is not actually true?
Yeah, that's a tough question. It really is because I don't know. It really depends on an institution and their experience and having people like Tro come in and myself come in. Guess what? We're never asked to do grand rounds because who sponsors grand rounds at all these institutions? Pharma. So if you're talking about other methods of getting off meds, they're not really encouraged by that. So right now, and this is really, I mean, when you step back for medicine, it's really a tough time because I will say I was naive for the most part. The governing bodies pass down and they say, okay, you can't do certain things, and you okay. But as an example, the reason that ABIM that I mentioned, I am no longer a part of that organization because what happened is we all got a letter from the head of that organization say, look, and I don't want to be controversial. I'm just going to say what the letter says. I'm not going to make a judgment one way or another. But this is at the very beginning when the COVID vaccine came out. And they said, if you say anything bad about the vaccine, we'll take you're unprofessional. You don't have any. Well, we were seeing some bad effects from colleagues and nurses and doctors and people that I worked with and friends of mine. So to say I can't talk about that that is a violation of medical ethics because my job is to say, look, here's the risk, here's the benefit. But they were saying you can only talk about the benefit, not the risk. I'm like, that doesn't serve my patient, and that's a violation of medical ethics. And then there was one thing after another, but it turns out in 2008 they passed a law saying that no doctor could take a pen from a drug rep because it would alter our prescribing habits and it would make us biased. So we couldn't take a pen from the drug reps or a cup or anything like that. But their bylaw says we could take whatever we want. Like the guys that are at the top of these things making these decisions, they said we could take, and this is actually Paul Thacker just published an article going through all this, and you think, wow. So they could take personal things, they could take money, they could, and they didn't have to disclose it. Now that's a conflict of interest, right? So if me taking a pen, if you take millions of dollars and I take a pen, and that's gonna, so you start looking at these, and it's really disheartening to see where medicine's gone, and
Interesting.
bonuses for doing certain procedures, bonuses for doing this, and you're looking like, wow, if you're part of the system, it's hard, and that's why stepping out independently, I can do what I want, and I don't have to. I mean, as long as it's obviously within the realm. But I don't have insurance companies saying, look, you didn't prescribe enough drugs to this person. This person needs to be on these meds. Well, sometimes they don't need to be on those meds, but they have a stamp that says this is what. So what I'm getting at is there's a lack of critical thinking and saying, okay, let me try this with my patient and see what works. Right.
Yeah.
When we start seeing people come off insulin, you say, well, shouldn't this be the standard of care? And that's really why low carb MD started. Because I said, look, I can't be the only one. In San Diego, I was the only one doing this. And my friends are looking at me like I lost my mind. But I was like, look at the outcomes. They're coming up the blood pressure medicines. They're healthier. And we had data on this stuff. And so, and even the other thing that was controversial back then that we touched on episode 13 was addiction and depression and anxiety. Getting better when you get your diet right and your exercise right and all those other things. So it was really an interesting ride to see. And we started low carb MD because then we could say, look, this guy in Utah is doing, this guy's in Nebraska is doing, all these people are doing this medicine with benefit to the patient. And that's how you change the standard of care.